Welcome to our third and last video on diseases of the colon. Let's begin. In this last section, we will cover large bowel obstruction, Ogilvie Syndrome, Colonic Volvulus, and Pilonidal Disease. Let's begin with large bowel obstruction. Large bowel obstruction presents with crampy abdominal pain, constipation, and abdominal distension. Vomiting is less pronounced as compared to small bowel obstruction and may contain fecal matter. Colon cancer is the most common cause in adults. Other common causes include volvulus, diverticulitis, and postoperative adhesions. Regarding workup, plain radiography is the best initial test to confirm the obstruction, especially in hemodynamically unstable patients. Abdominal CT scan is more useful to identify the site and cause of obstruction, and to look for any complications such as perforation and necrosis. Management focuses on treatment of the underlying cause. Decompression is indicated to unload bowel so as to prevent rupture. Surgical intervention is needed if there is suspicion of complications such as ischemia or perforation. Here's an abdominal x-ray of a patient with large bowel obstruction. We can clearly see the dilated large bowel loops suggesting obstruction. Now we discuss Ogilvie Syndrome. Ogilvie Syndrome is a condition in which a patient has clinical features and radiological evidence of large bowel obstruction, in the absence of any mechanical obstruction. Commonly seen causes include recent surgery, medical illness, for example sepsis, electrolyte imbalance, and certain medications that inhibit colonic peristalsis, such as anticholinergic agents and narcotics. Management begins with supportive measures, including withdrawal of offending agents, correction of electrolyte imbalance, nothing by mouth, intravenous fluids, and nasogastric suction. If there is no response, neostigmine is administered, and colonic decompression is performed if neostigmine fails. Let's take a look at this image of CT. It shows massively dilated intestinal loops without any mechanical obstruction, suggesting Ogilvie syndrome. Now we discuss colonic volvulus. Colonic volvulus is characterized by twisting of a loop of colon around its mesentery. This most commonly affects the sigmoid colon and presents as large bowel obstruction. This twisting of the bowel can also obstruct the blood supply, resulting in strangulation of the bowel. This may result in infarction and/or perforation of the bowel wall. Sigmoid volvulus is classically seen on an abdominal x-ray as a coffee bean sign. Management includes sigmoidoscopy for sigmoid volvulus, which both confirms the diagnosis and helps in untwisting of the sigmoid colon. Hence, it's both diagnostic and therapeutic for sigmoid volvulus. Surgical untwisting is usually needed for cecal volvulus. Here's an abdominal x-ray showing the characteristic coffee bean sign that is seen in sigmoid volvulus. The last topic of our discussion is pilonidal disease. Pilonidal disease usually occurs when an infected hair follicle in the intergluteal cleft is pushed inward through movements of the buttocks and thus forms a sinus tract leading to the skin. This causes recurrent local inflammation and/or infection. It presents as painful red swelling in the intergluteal cleft. Risk factors include obesity and prolonged sitting. This image shows two pilonidal cysts in the gluteal cleft circled in green. Pilonidal disease is usually a clinical diagnosis. The treatment is incision and drainage of acute abscess, followed by removal of the whole pilonidal tract to prevent recurrence. Let's end our section with a board-style question. An 81-year-old man presents to the emergency department with vomiting and severe abdominal pain. He has past medical history of osteoarthritis and constipation. His vital signs include a temperature of 36 degrees Celsius, a blood pressure of 135/80, a heart rate of 84, and a respiratory rate of 15. Physical exam reveals left lower quadrant pain with no rebound tenderness or rigidity. Abdominal x-ray shows twisting of the sigmoid colon around its mesentery. Laboratory studies are unremarkable. Which of the following is the best next step in the management of this patient? A. Laparoscopy. B. Laparotomy. C. Sigmoidoscopy. D. Air enema. This elderly man presents with vomiting and severe abdominal pain. The physical exam reveals left lower quadrant pain with no rebound tenderness or rigidity. Abdominal x-ray shows twisting of the sigmoid colon around its mesentery. These are the classic signs and symptoms of sigmoid volvulus. The patient's vital signs are unremarkable, indicating that he is hemodynamically stable. Laboratory studies are also unremarkable, making bowel ischemia and necrosis unlikely. Therefore, this patient needs sigmoidoscopy with detorsion. The correct answer is option C. Here's a slide reminding us of the management of sigmoid volvulus. Let's discuss why other options are incorrect. Option A and B are incorrect because laparoscopy and laparotomy are reserved for hemodynamically unstable patient with bowel ischemia and necrosis. Finally, option D, air enema, is avoided in sigmoid volvulus because it can cause colonic rupture. And that concludes our lecture on diseases of the colon.